What I want to share with you in the time that I will try not to go over, is just simply an overview of what this whole thing on trauma and health is all about. You've probably heard or seen the terms trauma-informed care or being trauma-informed or trauma in general. I mean, on Instagram, there's like this cottage industry about, I guess everybody's a trauma therapist now. And, you know, all that aside, I'm not going to get into that area so much today. What I'd like to center us on in this discussion is the question: if our experiences in childhood indeed shape our health, how should this inform or influence the way I care for my patients in this next hour? So this talk is not just about, what I'll add to it, this talk is not just about, reframing our understanding of patients and people, understanding it from a life course perspective, but it also, I think, is very much about our own wellness. And specifically, getting into moral distress and moral erosion that often occurs or accompanies burnout. So in that sense, I would ask you just, consider this talk as not just information that will inform your patient care, but also another way to think about preventing burnout. Okay, so that being said, let me start off with a story. And so as I start this presentation, I do realize that many of you probably have heard about ACEs before. And so if that's the case, I certainly hope that there's something new that you can gain from this. But if you haven't, I'm really glad that you're here. And so this story, I always tell at the beginning of an ACEs presentation because it always, for me, sets the tone. It's kind of a paradigm shifting frame that points out or highlights why this topic of ACEs, why it's kind of provocative in one sense. So if you come back with me to the mid 1980s, we're in San Diego, California. And at the time, there was a physician named Vince Felitti, who was a preventive medicine doc at Kaiser Permanente. Dr. Felitti was in charge of overseeing this weight loss program that actually was quite successful. So men and women would come in, they would lose weight, they would actually keep it off as long as they stayed in the program. But over a period of 5 years, he noticed that about half the participants just dropped out unannounced, unexpectedly. Despite, and what really confounded him was that most of the people who were leaving the program, who left the program, were either already at their goal weight or they were well on their way to their goal weight. They were losing weight. So why would people leave a program if it was actually succeeding in what it was intended to do? So troubled by this, Dr. Felitti, he decided he would try to interview as many of these ex-participants as he could, and he got to about 285 people. But it was through one woman's story that he almost stumbled upon something unexpected, a surprising phenomenon, if you will. So story goes that while in this program, this woman came in and she weighed over 400 pounds initially. As she participated in the program's activities, she actually got down to about 130, remarkable decrease in weight. But when she hit this weight of about 130, she suddenly disappeared. And about 6 to 8 weeks later, she comes back having regained almost 40 pounds. And so when Dr. Felitti interviewed her, she said that one day, after she was around this weight of 132, 135, at work one day, an older coworker, an older gentleman, he hit on her. He made a sexual proposition to her that was completely unexpected, completely unsolicited. And so when that happened, it actually triggered these deeply buried memories for this woman of her own childhood, a period of sexual abuse at the hands of her own family member. And this happened over a period of years. And it was during that period of abuse that she began this pattern or this habit of overeating, of binge eating to cope. And what she noticed initially on the subconscious level was that as she gained weight, she became less and less noticed by that family member who was committing this abuse. And as she got older, she, again, subconsciously initially, but over time, she became more aware of it. She generalized or extrapolated that strategy of eating and gaining weight as a way of protecting herself and going unnoticed from other potential predators in her life. In a different conversation with a different participant, a very similar themed quote came out, and the participant said that being overweight is overlooked, and that's the way I need to be. Well, at this point, Dr. Felitti, he knew that he was onto something that wasn't well described in the literature. So he went back to his team and he said, hey, we need to ask everybody about what their experience in childhood was like, because it could be a reason why they decided to leave the program today. And we have no understanding of this right now. And what they found in this small case control study, again, of about 285 people, was that most people had experienced abuse in their childhood. And that sexual abuse was particularly common, especially among those who left the program unannounced. And so the key lesson for Dr. Felitti and his team, what allowed him to see, in a way, you know, the forest for the trees, if you will, the big picture perspective that was going on, what they learned was that what they perceived to be the problem, in this case, obesity, binge eating, overeating, a sedentary lifestyle, what they perceived to be the problem in these participants was actually a solution for them. It was a defense mechanism, an adaptive survival skill, but one, of course, that came with very serious health consequences. And as it turns out, this phenomenon of how we adapt to lived experiences, it includes a lot of what we would probably all agree are dysfunctional or problematic behaviors in society today. Things like substance use disorders, or dissociative behaviors, apathy, or hypervigilance that seems out of proportion to the situation at hand. So not only is maladaptive coping incredibly common, it turns out, it's actually at the same time really very, very much under-recognized. And that's why Dr. Robert Ross, or Bob Ross, not the painter, but the pediatrician and CEO of a large foundation in California, some years ago, he was quoted saying that of all the things, of all the public health issues that really plague his state, California, childhood trauma is the #1 public health crisis. And not only that, it's a crisis that's just hidden in plain sight. What our job as health providers is really to have eyes to see and ears to hear and minds that are curious and hearts that are open, because without this sort of disposition or inquiry of disposition of inquiry or openness, we will continue to miss each other, and these phenomena of maladaptive coping will continue to go unrecognized. So with that, I want to just jump to the outline. What I'd like to do in the time that I have is cover 3 main topics. First, what's this whole thing about ACEs and health outcomes all about? 2, what are the underlying mechanisms that link experiences of stress and adversity and allostasis in childhood with all of these undesired health outcomes in adulthood? And then 3rd, what can I do, what can you do the next time we see patients, which might be, you know, in less than an hour. All right, so our story picks back up. Dr. Felitti knew, again, he was onto something that just wasn't written about in the medical literature. So he flew from San Diego to my state in Georgia. He came to Atlanta, teamed up with another physician at the CDC named Rob Anda, and together they became the co-principal investigators of what we call today the Adverse Childhood Experiences Study. Now, this is considered a landmark public health study, a seminal study. It's been cited over, the last count I saw was over 17,000 times. And it was a monumental effort by the CDC and Kaiser Permanente. The thing about this study was that it's not new. It wasn't published last year. It wasn't published 5 years ago or 10 years ago. This study was published in 1998. It's well over 20 years old. And I'm willing to bet that there are many of us here right now who have never heard about this study. Now, one caveat that I'll add before I go on is that when we say the ACE study, really what we're referring to is the ACE study series. So there was an ACE study group that was formed, and the ACE, the original paper, was just one of about 80 to 90 different manuscripts that came out of this ACE study series. But fundamentally, what these researchers did was they recruited over 17,000 adults And they asked all these 17,000 adults about 10 different categories of childhood trauma, childhood adversity that was experienced before the age of 18. And so these 10 categories span 3 domains of abuse, neglect, and household stress. Within abuse, they asked about physical, emotional, or sexual abuse. Within neglect, they asked about physical or emotional neglect. And let me add here that of the ACEs that I'm going to show you on this slide, emotional neglect is one of the worst ACEs. Many other types of trauma, like physical abuse, for example, we can remember as adults and ground that experience in reality. We can recognize it, remember it happened, and sort of be able to put that in the context and say that was wrong, it shouldn't have happened. But what we tend to say, what people who've experienced emotional neglect tend to say about their past is not my mother or father or family was not there. What we say instead is our parents or my parents did the best they could. We actually change our sort of reference point. We lower our expectations, and in so doing, we lower our expectations for the love and affection that we expect in our lives. That was just a digression that came to mind real quick. So anyway, abuse, neglect, and they also asked about household stress, 5 different types. These included mental health problems and substance use disorders in a family member, an incarcerated relative, intimate partner violence against the mother, and then lastly, parental separation and divorce. Now, one thing that I want to say before I jump to the ACE study series, again, as I mentioned, was a sort of prospective study group. And I'm going to condense all of their findings into 3 key findings. Now, before I kind of jump into and kind of explaining why ACEs are common or what they saw, let me just highlight who was in this study. So if you remember, the study was published in 1998, like I just said. So they were collecting data in the mid-90s, and this was in San Diego. And so of these 17,000 participants, 75% were white, 75% had gone to some college or received some type of college education, and 100% were insured. So when you think about the participants in the ACE study series, it's an affluent group. It was probably among the most affluent of participant groups that has been studied in a sort of large scale epidemiological study. So keep that in mind as we sort of make these connections between ACEs and health outcomes. So the first thing they saw, first key finding was ACEs were incredibly and unexpectedly common. How common were they? Well, again, of these 17,000 adults that were surveyed, about 2 in every 3rd adult, 64%, had 1 ACE or more. Again, that's if we generalize that to our group on this call, that's almost 2 out of every 3rd person here right now. So trauma isn't this problem that we can just reflexively attribute, like society tends to do, as something of those people, however you want to define that. I mean, we know from this study and many others since then that ACEs occur across every race, every ethnicity, every income level and community. This is really something that hits close to home for everyone. And then to go one step further with respect to local data, I tried to find some local ACEs data in DC. It was a little bit tricky, but what I did find was that the prevalence of 2 or more ACEs among children, so these are all children younger than the age of 18, the prevalence of 2 or more ACEs was 19% compared to 16% in the original ACE study. I'm willing to bet that it's probably higher, but again, I wasn't able to find that data in a short period of time. So ACEs are common, and so that's the first key finding. The second key finding, and this is what had my jaw on the ground the first time I heard about this topic, was this association, this robust association between ACEs and a multitude of undesired health outcomes. So what they found was the higher number of ACEs a person had, the higher risk that person would be for some of the most common health and behavioral problems that we see in internal medicine every single day. Things like health risk behaviors such as tobacco use disorder, heavy alcohol consumption, illicit substance use, mental health problems like depression, anxiety, PTSD, even a history of suicidality has been implicated. And then ACEs are associated in a dose-dependent manner with an array of chronic diseases. We're talking about things like COPD, diabetes, non-skin types of cancer, adult onset ischemic heart disease, and stroke, even obesity and liver disease as well. And then the ACE researchers found that ACEs are also strongly related to more socially facing outcomes like the ability to maintain financial stability or hold down a job over a long period of time. And then in the pediatric years, we know a lot about how ACEs really disrupt and decrease the chances of academic success in children. So just to show you some of these, the magnitude of some of these associations, when they compared individuals with 4 ACEs or more to those with none, after adjusting for common demographics like age, race, ethnicity, sex, gender, socioeconomic status, they found that the risk or the likelihood of alcohol use disorder, again, among those individuals with 4 ACEs or more, was 7 times greater compared to those with no ACEs. For substance use disorder and depression, over 4 times greater, COPD over 4 times greater as well, and for CVD and cancer, over 2 times greater. When they looked at, and I just wanted to show you a slide that highlighted this dose-dependent or dose-response relationship. So what you see on this slide in the different colored bars are the different ranges of ACE scores, so how many ACEs each person had. And on the y-axis is simply prevalence. And so what you can appreciate is that whatever outcome is shown here, as the higher the ACE score, the more prevalent each outcome: job absenteeism, financial problems, and job problems in general. Whenever you see a dose-response relationship from an observational study, it cannot prove causality. And I'm really careful to say ACEs are not causing all of these, but they're certainly related in some way and part of the pathway in the development of these risky outcomes. I think one of the most stunning findings from the ACE study series was one of the later studies that came out. So after about 10 years of prospective data, including death certificates, what they found was that for those adults who reported no ACEs, their lifespan was on average about 80 years, which is comparable to the national average lifespan in our country at the time. But for those adults who had 6 ACEs or more, their lifespan actually went down by 20 years to an average of 60. Again, the measurable difference between these two groups being the burden of trauma that they experienced before, or not just trauma, but adversity that was experienced before the age of 18. Now, in children, I'm not going to show you too much data on children just to kind of keep the scope on adult patients. But I'll just say very quickly that ACEs do not skip over the pediatric years. We know a lot about the way trauma adversity shows up in children, and the predominant way it shows up before you see sort of these end health outcomes like chronic diseases. The way it shows up is actually in disruptive behavior or challenges navigating social relationships, peer relationships, relationships with caregivers, all throughout childhood. So if we just take a step back for a moment and think about what we've covered, all the data that we've seen so far, I hope what becomes clear, I hope I made the case that the experience of trauma for a lot of people is not just an experience, right? It's not just a part of someone's past. On the contrary, the experience of trauma can be devastating across multiple domains of well-being for one person. And so when we interact with someone who may have had experiences of trauma or adversity growing up, it's important that we acknowledge the range of domains that could potentially be affected. If you see substance use as a result of trauma, I would say chances are there are other domains in their well-being that have been impacted by trauma and adversity. Now, one question I get asked quite often is, hey, aren't there more than 10 ACEs? Like, there are definitely more types of adversity that people go through than included in the ACE study, right? And the answer is absolutely yes. The original ACE study researchers did not intend to draw boundaries around what's considered trauma, what's not. They actually just pulled together existing survey questions that happen to include these 10 types of adversity. But you could ask any of the ACE researchers today, hey, are there more than 10 types? They would say, yes, absolutely. The way I like to talk about the more broad level types of trauma or adversity is to use this illustration, which we call the tree of ACEs. This is actually adapted from Wendy Ellis's group from the University of Maryland. But if you can think with me, look at this tree and imagine that the leaves and branches represent the conventional ACEs or the interpersonal ACEs that occur in the home. Things like abuse, neglect, and household stressors. Now, every tree is growing out of a trunk with many roots in the ground. And the roots are what we refer to as adverse community environments. These are things like poverty, violence in the community, racism, discrimination, economic disadvantage. In and of themselves, these are all adverse events, but they also provide this sort of context or pressure out of which the interpersonal ACEs, those leaves and those branches, might occur at higher frequency or higher severity or in the absence of a mitigating resource. For example, poverty, the adverse environment of poverty is like pouring gasoline on the fire of ACEs. It just makes the impact of interpersonal trauma so much worse, especially if it means that there's not an existing resource in the community to help with that problem. For example, if there's no substance use treatment available locally in a community and a caregiver is really struggling with that. Now, this illustration actually goes one step further. So as the tree grows, the health of the tree that grows out of the roots, in a way, depends a lot on the quality of the minerals and nutrients in the surrounding soil. So we actually call the soil adverse collective historical events. These are events I put examples in recent history that have conferred an inter or multi-generational impact, things like slavery and genocide, mass incarceration, and of course today I would definitely put on there COVID. There are studies that have shown, and this is not some empty, unbased theory, but there are studies that have shown that trauma can actually be inherited across generations through through how trauma actually influences our epigenome. So the bottom line point I want to highlight on this slide is that anytime we're talking about ACEs, anytime we're talking about adversity or allostasis, we are always talking about injustice and inequity. You cannot decouple the impact of historical events, adverse community environments from the reality and how much they increase the impact of trauma and adversity that occurs in the home. In a more recent study from some of my colleagues who at the time were at the CDC, they asked the question, okay, the ACE study was done, it was published in 1998. How about in the 2010s? Like what's the distribution of ACEs right now in our country in a population that's more representative of the actual US population? After surveying about 250,000 adults, what they found was that yes, while ACEs are universal, again, while they cut across every social demographic we can think of, at the same time, they're disproportionately common in communities that have endured systemic oppression, marginalization, and neglect. This should not be a surprise to us. So I point this out to say, when we look at something like health disparities in the US, end outcome health disparities, specifically racial health disparities, it should be no surprise why these exist as well. The root cause of these disparities, such as heart disease shown here, is not simply related to differences in dietary patterns or exercise patterns. The root cause, I would argue, it has a large part to do with historical traumas that have impacted generations upon generations of people in a myriad of ways. So ACEs are strongly, robustly associated with a multitude of negative health outcomes. If the first 2 points are true, well, the next part we get into is how ACEs disrupt brain development. And that really is the bridge that connects ACEs with health outcomes. So let's talk about the how. Here's the fundamental question that we're asking here. How the heck are these experiences that occur outside the body, how are they disrupting our physiology within? And how are they promoting such a wide array of problems? I know I already gave the punchline away, but it really comes down to how psychosocial stress, adversity affect our brains and our brain development if it occurs during sensitive periods of growth and development. one fundamental truth that we've learned over the years in sort of out of the context of this nature versus nurture argument is it's both. Yes, certainly genes matter in informing people's health and health trajectory, but experiences matter a lot too. Brain development is actually fundamentally experience dependent. And so because of this, and really we're summarizing decades of convergent research from multiple fields, the experience of adversity and trauma can actually provoke a stress response pattern, which we call toxic stress. Toxic stress is the kind of stress that is so severe that it can disrupt normal brain development, which can disrupt brain function, and in severe cases, it can disrupt even brain growth. Now, the working model that there's consensus around today is, again, another way to think about toxic stress is that it's kind of like a hijacked stress response system that's dysregulated, it's unpredictable, and if this pattern or this dynamic is experienced in the early childhood years, 0 to 6 years old, again, that's a very sensitive period for brain development. Toxic stress can profoundly disrupt neurodevelopment, which is the brain architecture, brain function. Disruptions in neurodevelopment will inevitably lead to problems with behavior, such as the ability to emotionally regulate or cope with stressful situations. Toxic stress can disrupt our HPA axis, which promotes dysregulation of cortisol metabolism and other inflammatory mediators. That our endocrine system, of course, is highly regulated and related to our immune system. And there have been studies that have shown, albeit they're observational studies, that have shown compellingly that that people with a high burden of trauma in their childhood are more likely to have those acute infections like URIs, flu, et cetera, relative to those who have not had those similar burden of trauma. And then lastly, toxic stress can influence our epigenome and promote intergenerational transmission of the consequences of trauma. So all in all, it's really this multifaceted impact of toxic stress that's housed within our brain that over time, this is that allostatic load, allostatic pressure that can lead and promote these range of health outcomes, health risk behaviors, mental health challenges that we see downstream. How do we know that this pathway of toxic stress or maladaptation in response to allostasis, how do we know all this is valid? Well, I think this is where things start to get somewhat interesting or more interesting. And let me show you this paper that was part of the ACE study series that kind of highlighted, well, there actually might be a direct effect of trauma on the development of heart disease. So for the sake of time, let me just show you what they saw. Basically, when you look at the association between ACEs and heart disease, we know that if you adjust for social demographics, which is shown in the blue bar here, that there is a dose-response relationship. People with high ACE scores are much more likely to be at risk for ischemic heart disease compared to people with lesser ACE scores. And I've grayed out the bars that where it did not meet statistical significance. After adjusting for traditional heart disease risk factors, such as high blood pressure, diabetes, smoking, and elevated BMI, and after adjusting for psychological risk factors like depression or an angry affect, when they took out the effect of those risk factors, they nonetheless, in the red bars, saw a persistent association that was dose dependent between ACEs and ischemic heart disease. What this is saying, bottom line, is if you take out the effect of cigarettes, high blood pressure, diabetes, depression, there's something about ACEs and ischemic heart disease that's still occurring, that's still ongoing. This more recent study, I think this is a really fascinating study as well, helped us to understand a little bit more what's actually happening on a biochemical level. So this is a study that was published from a group out of Boston. It was published in Lancet, again, it was a couple of years ago. And it really highlights the relationship between stress, the role of the amygdala, which is our fear processing center, very important in our stress response mechanism, the role of the amygdala, inflammation, and disease. And so what they did in this study was they took about 300 people and they had them undergo whole body PET CT. And then they used some existing validated methods to assess the activity level of the amygdala. And then after that, they kept track of, this was a prospective study, so they kept track of new onset cardiovascular events like MI, angina, and stroke. And what they found was that the higher that higher amygdala activity, which is shown here on the right column, actually predicted incident new onset cardiovascular events. This process seemed to be mediated by the presence of increased inflammatory mediators, both in the bone marrow shown here, this is the vertebral column, as well as directly within the arteries themselves. This is the ascending aorta that they're trying to show here. And so the mechanism they propose, I would say compellingly, is that in response to chronic stress, the amygdala initiates this cascade of pro-inflammatory events that over time, if it's not buffered, if it doesn't go away, if it's not resolved, will promote adverse cardiovascular events. And it looks like it's happening through atherogenesis. When they assess the risk of a cardiovascular event from high amygdala activity, again, they defined high amygdala activity as like greater than the 90th percentile. Even after they adjusted for common covariates of cardiovascular disease, common confounders and covariates, age, sex, gender, the Framingham risk score, which you can Google, and other cardiovascular risk factors like smoking and high blood pressure, diabetes, after adjusting for all of these common risk factors, the association still held. You can see all of these values here. Their confidence intervals don't cross 1. So it appears to be that there's some direct effect that trauma has on the amygdala, which then has a direct effect on the development of adult onset ischemic heart disease. And the last figure I'll show from this study is a Kaplanmeier curve. They compared participants with high amygdala activity to those with lower, who are in green. So high amygdala activity is in red, low is in green. And the y-axis is the percent of patients who made it through the study period without a cardiovascular event. And what we can appreciate from this graph, I think it's very clear, is that patients with high amygdala activity were not just more likely to develop a cardiovascular event, but actually develop it much, much sooner than compared to those with lower amygdala activity. So let me pause here for a second and say, if any part of what I just shared caught your interest, and you're someone who came into residency not sure what you want to do, but this really is like kind of tickling your ears right now, and it's drawing you in, I would highly recommend you check out this paper. And I would also add that, for those of you who came in undifferentiated, but really had a desire to pursue or really explore what you can do in health disparities, I think for internists, this is where it's at. I think there's a lot of questions that have left to be answered in regards to how these psychosocial adverse experiences are influencing our physiology. Can we measure it? Can we detect it? Can we study it more in a more robust, organized way? I think we can, but we just need more people to do it. One thing I want to highlight very quick too is how the effect of chronic stress on the brain can influence regions of the brain that mediate specific behaviors. Regions of the brain like the amygdala and the prefrontal cortex, which are very, very important for navigating our world successfully. Now, this is a very, again, simplistic illustration. It's not comprehensive, but the general idea is that toxic stress promotes overactivity of the amygdala, that part of our brain that processes fear and threat. And as the amygdala is activated, it actually sends negative feedback to the areas adjacent to and within the prefrontal cortex. A good example of this real time is when you're driving down the highway and someone cuts you off. You don't sit there and plan to swerve or dodge that car coming into your lane. You do it instinctively, and that's because your amygdala is so quick to process the input from your visual cortex, and it guides your muscles to safety without you even thinking about that on a conscious level. Now, the prefrontal cortex, you might remember, is the most complex part of our brains. It's responsible for our higher level functions, self-control, planning for the future, displaying empathy, or reasoning, or controlling impulsive behavior. So the key here, what I want to highlight in this slide is that when the amygdala is activated due to a perceived threat, it doesn't even have to be a real objective threat, but if it's activated due to a perceived threat, the prefrontal cortex is essentially not in control. It's functionally offline. And when a person is in survival mode, this is why they are not as receptive to rationalizing language or logic or reason. Imagine if your brain is telling you there's a grizzly bear in the room, the goal for you is not to think, but to survive. And so, of course, this is going to have very real life implications on behavior. And so in the clinical context, what might we see? Well, before I kind of show you some examples, let me just say very quick that a lot of times, despite our best intentions, many of our patients, they don't find hospitals or clinics to represent places of healing. In fact, it's not unusual for people to feel that the clinic or hospital is actually a dangerous place, a threatening place for them. So I think it's important to realize that just the very fact of being at a hospital or a clinic can put a patient on edge or a family member on edge. It can make them more susceptible to having or exhibiting that trauma response. So with that said, let me highlight three, I would say, common behavioral outputs that we see in the setting of toxic stress. The first one is hypervigilance or hyperarousal. This is a heightened sense of a perceived threat or danger. This can show up as an intense affect. It can show up as anxiety, excessive worry that might seem out of proportion to the issue at hand. Hypervigilance can make something like pain management really, really challenging if the patient perceives that, hey, if you mess with my dose or mess with my frequency or the number of refills I have, it's going to result in a bad outcome. Hypervigilance is a stress response. It's not this neutral part of their personality. It's a stress response. Another output that we commonly see is emotional dysregulation or trouble coping with in situations that other people may not have as much challenge, may not face as much challenge to cope themselves. And so this is the ability or inability to regulate one's affect, again, under stressful or mildly stressful conditions. This could be occurring in that patient who is, beside themselves, yelling in the hallway because they might have been waiting on the doctor after being triaged for 45 minutes. Or this is a true story. I experienced this 6 months ago. And this could be occurring in the patient who is admitted, needs to go to dialysis, but won't, refuses to get on to go with transport because a specific type of food wasn't on their meal tray for breakfast that morning, right? So these can be very challenging and very frustrating situations for us. But if we understand that this is also a stress response, it will change the way that we approach how to solve and reconcile these types of challenging events. And the third one is that's very, very common that we see all the time is avoidance. This is avoiding thoughts, memories, sensations, even conversations that remind us of these painful past experiences. This is a very common maladaptive coping strategy that often leads very much to substance use disorders. I have yet to meet a person with a serious alcohol use disorder who wasn't trying to run from pain. It just doesn't happen. No, I have not met someone who is a heavy drinker, has cirrhosis and pancreatic issues, who wasn't trying to run from pain. But how do our health systems tend to view people who have an alcohol use disorder and come to the ED a lot? Do we treat them with an understanding that the drinking is actually that person's attempt to cope? So before I move on to the next section, to kind of put everything we've been talking about in a simplified pathway, what we know to be happening is that there's wide variability in the long-term effects of adversity. Some people actually never develop any problems or symptoms after ACEs and they go on to live a healthy life. Where some people in the middle here, they might experience minor or mild disruptions in their physiology, but they don't rise to the level of apparent symptoms or signs or behavioral changes. But nonetheless, decades later, they might show up with disease, disability, and so on. And then, of course, we've been talking about this third pathway of people on the bottom. There are those who will go on to develop after ACEs, those social, emotional, cognitive impairments, adoption of health risk behaviors, which then contributes and lends itself to disease, disability, and early death. Okay, so in the 10 minutes I have left, I hope you're hanging on with me here. I have good news, and I would not care about this topic if there wasn't something that we could meaningfully do about it. After we spent all this time unpacking the problem, we have strong reason to hope, because here's the reality, and I kind of alluded to it on the last slide. We know that not everybody who's experienced trauma in their childhood, who's experienced adversity in their childhood, is going to be doomed to negative consequences. We all know people in our lives, and it might even be you listening, attending this conference right now, who made it despite the odds. What is it about the people who were able to find success and adjust and have a healthy, adjusted life despite having those high numbers of ACEs? And so the operative word that is really a buzzword for us in the trauma space is resilience. This is such an important term that I worry sometimes it's being co-opted into corporate circles and HR, and it becomes part of this like buzzword that gets thrown in wellness, seminars. Resilience is such a critical concept to understand well. And so what I want to say about resilience is that, first of all, it's this ability to adapt and succeed in the face of adversity, when someone can bend but not break. And what we have to know about resilience, very importantly, is that not a single person on this earth is born resilient. You might be born with a certain kind of temperament, a proclivity to be, a worrywart or completely, apathetic to worry. But resilience is a trait that is built through a child's and an adult's social ecology. It's actually the type and the quality and number of positive relationship a person has in their life that helps to form and the foundation for resilience. The second thing we have to know about resilience, and this is why it matters, is that when it's present, that means that even in the face of future adversity, of future trauma, that person has a higher likelihood, a much higher likelihood of success and being able to adapt and succeed. What are the critical factors necessary for cultivating resilience? The game changer, the most important one to remember, the foundation, is healthy relationships. And that is I'm spilling the beans to tell you, this is what we need to think about with respect to our patients. A safe, stable, nurturing relationship is the foundation upon which all of the other factors that promote resilience are built. So much of trauma can be represented by failed or broken relationships. And so the way we actually promote resilience and heal from trauma, it starts with a sense of restored, safe, stable, nurturing, understanding relationships. Again, the data bears out, I don't have time to show you all of it today, but the data bears out, this is a game changer in children, equally critical among adults too, because adults can heal from trauma as well. The bottom line here is, whereas adversity really makes us vulnerable, healthy relationships are the buffer that help to protect us. And so what we've learned about resilience over the years is that it can revert what could become toxic stress back into tolerable stress, again, where you bend but don't break. And the sort of neuroscience justification for this is simply neuroplasticity. Obviously, neuroplasticity is greatest in early childhood, but adults have it too. People can still heal from insults like strokes and recover and regain a lot of their function with deliberate therapy. And so if ACEs are this risk, so another sort of pearl that comes out of this is that ACEs are a risk factor for negative health outcomes, not a guarantee. And if this is true, what then should be our approach for patients who might have experienced trauma in their childhood? And this is where this term trauma-informed care, I hope it's starting to make sense. Because when we talk about care that is trauma informed, we're talking about a framework, not a checklist. It's a framework, and it's grounded in one, understanding what trauma is, two, understanding how trauma affects us, and then three, asking the question, well, how should I respond? Trauma is something that we're actually incredibly good at hiding. That's why, again, at the beginning, I showed you that quote from Dr. Ross, who said that trauma is a crisis that's hidden in plain sight. We know it's common, but yet at the same time, we don't know who has or has not had an experience of trauma or adversity earlier in their lives. And so what trauma-informed care really starts with is this paradigm shift of how we acknowledge, how we understand problematic behavior or dysfunctional behavior. And so what the main logic behind trauma-informed care is that instead of approaching each other with a what's wrong with you sort of mindset, again, when we see that dysfunctional behavior, what it's saying we should do instead is ask, what's happened? When we see that person in clinic who has relapsed on drugs for the 7th time, and it sends them into decompensated heart failure, or we see that person who has an A1C of 15 and again hasn't picked up their insulin from the pharmacy, or we see that person in clinic who is yelling in the hallway, again, because they didn't, they've been waiting for a long time. And there's that part of us that wants to push back and say, what's wrong with you? Don't you understand? Why can't you just blink? What trauma-informed care is asking us to do is, again, pivot away from that question and ask instead, what's happened? What don't we know? And in a way, for me, it's like, I actually say this to myself before I go into every patient room, whether inpatient or outpatient. For me, it's like a reset button for empathy. It's something that I kind of say to myself before I go in to kind of clear off my mind what happened in the previous encounter, especially if it didn't go as well as I hoped it to go. All right, for the sake of time, let me just highlight a couple things here. In terms of sort of mechanizing or actualizing trauma-informed care, the steps include realizing the effects of trauma, which we're doing through this talk, recognizing the signs and symptoms of trauma when they're apparent in the person in front of you. Third is knowing how to respond from an empathetic perspective. And then fourth is thinking about ways to avoid re-traumatizing people. Because again, the fact that someone has to be admitted to the hospital, that's not a place that most people want to be. The one that I want to highlight and just kind of say a couple more words on here is the recognize piece. I think recognizing the signs and symptoms of trauma is one of the hardest things to do. It's not a call to judge people, prejudge people and assume that you know everything about their history. Recognizing trauma is actually asking us to modulate our response when a person is activated in front of us. When you go into the room and that patient is angry, they're livid, and they just start to take it out on you, we all have that impulse to want to defend ourselves or say, don't blame me, it's not me. We all have that sort of knee-jerk response built within us to not accept blame or even maybe lash back out. But what this R is asking us to do is to check that impulse and really that impulse comes from a what's wrong with you lens, not a what's happened. And so this is really, really hard. So let me ground this in some real life examples. Okay, so the next time, here's a list of some not uncommon situations that we encounter. A person with a strong odor of alcohol during a clinic visit, a person who has repeated relapses of substances, they might need have multiple admissions as a result. A person with chronic unexplained pain or has medical mistrust, or they're hypervigilant periodically. The next time we see patients exhibiting these types of behaviors, we know these are obviously the ones that really can be frustrating or exasperating, but they're precisely the situations in which we should be responding with what's happened, what's going on underneath that behavior, what don't I understand about your situation and your background that I need to understand to help understand the situation in a very real way. Okay, so I know I'm almost out of time. I want to just run through some other applications, things that you can think about. If you want to save this as a screenshot, this is a free workshop module that's available through the AMA MedEd portal. It's self-explanatory, so a resident, you could print this off and do a small group with it. It's a very complete workshop, start to finish, and it kind of goes through some steps, some things you can think of before the exam, during the exam. It has a nice array of photos that can show you how to conduct a physical exam in a more trauma-sensitive, trauma-aware fashion. And I would put this in the bucket of universal precautions. I have a soapbox about how we approach substance use disorders. But the main thing I want to leave you with is I think we really should fight to reframe how we understand substance use. And what I've learned over time is that we can't rely on our most experienced docs to change their attitudes and perceptions. Really, the change in our bias starts with us, starts with our generation and you all in training. And so substance use is not a willpower weakness. In fact, I would argue that substance use should be reframed. Sometimes I want to call it self-medication disorder, because of how much it actually is the truth. And then secondly, could help us if we call a substance use problem self-medication disorder. To me, it helps frame my approach to how to work with that patient in a more compassionate lens. Okay, the last thing I want to highlight is acknowledging the impact of trauma in our own lives. You all have entered residency in a really, really difficult time in our country's history during a pandemic. If you're a second year right now, I feel for you. I mean, you had to start last year in July of 2020, right in the middle of the pandemic. It's important to acknowledge in as much as we can, the reality and the impact of what we've been through, not just this past year, but in our childhood as well. Why is this important? What happens when we get stressed? The same things that happen to our patients. We get hypervigilant, we get emotionally dysregulated, we avoid too. And so it's really important that we understand the ways that trauma shows up in our own lives if we want to be present and a grounding presence for our patients. Lastly, let me leave you with a book recommendation. This just came out a couple months ago. Interestingly, Oprah is also on the trauma ACEs train now, but she co-wrote this book with a leading psychiatrist in the space, Dr. Bruce Perry. This book is, if you have a family member you're thinking about as I give this talk, or a friend who you're just like, man, I think it would really help for them to understand how trauma is really showing up in the family or in their own lives or in the lives of their loved one. I highly recommend this book. It's a very easy read, but it has a lot of just solid information that's grounded in science. You do not need to worry about the person reading this book reading something that is not informed by data and evidence. So with that, I know I'm a bit over time. Let me just go ahead and show my email in case anybody has any questions. But I would be happy to take any comments or questions. Thank you all for your attention. I can't see you, but I appreciate your participation and engagement for this time. Thank you so much.